When you are fed using bottles, this is simply a suction movement. You just, if you do this with your mouth right now, you feel where the pressure goes to. So you are compressing your jaws. You're not stimulating growth. You're doing the opposite. You're creating vacuum inside your mouth. That's the way to extract the milk from the bottle when you do this.
And you can feel the cheeks compressing the jaws.
And while suctioning, you develop your cheek muscles they get strong, and they get to prevent the natural transversal development of the jaws. So you create an inverse muscle behavior that will lead to improper craniofacial growth.
Conventional medicine doesn't accept the fact that bad environmental conditioning can lead to facial deformity or facial underdevelopment in the first place.
Absolutely. We learned that it's purely genetics. There is nothing you can do about it. You are born this way. You are condemned to do, and you can only do minor compensations. You move your teeth around, you have lots of limitation, and that's it.
Dr. Soares, thank you for joining me today on this podcast. You're an expert in improving myofunctional and airway outcomes in children, but I want to ask you, how does one raise a child to not need orthodontic intervention in the first place?
Aaron, first of all, thank you for the invitation. It's a huge pleasure for me to be present here as a fan myself, as a fellow advocate for what you just said, for airway health and the work you do in raising awareness and bringing this knowledge to a wider public. That's truly commendable. So the US, this is a very good question that we don't have a straight and very easy answer to, because problems can arise from many different factors that would range from genetic factors. And more important, that's what we have more power on changing, is what some call the epigenetic factors, which is essentially environmental behaviors that would change how our genes express. There are things that we can change, for example, malformations or certain genetic traits that would express, causing some alterations on facial development. They are inherited and they will express regardless of what you do. But most of our facial development happens in response to what we do regarding primarily breathing and how our facial muscles behave. So facial growth, we are born with the ingredients, but the final recipe will be tailored based on what we do with our functions. Primarily, again, breathing and oral functions. It definitely dictates how the face expresses itself. So what can we do to prevent alterations in growth and development that would lead to a necessity of further treatment later in life? First of all, if we could choose one main thing to make sure that the baby will be able to have, is establishing nasal breathing. Nasal breathing is the number one ideal function that would lead to normal growth. What needs to be done in terms to establish the nasal breathing? That's another conversation. It could be from treating and preventing infections, removing any type of obstructions throughout the airways, not only inside the nose itself, but keeping the nasal airways open and establishing nasal breathing is fundamental. After that, it comes, once you are able to breathe through the nose, the natural response to it will be establishing proper oral posture, which means tongue in the roof of the mouth. We need to learn and to establish and to practice resting the tongue in the roof of the mouth. The best way to do this is, again, breathing through the nose, but also more importantly, eating hard food. So establishing hard diet would be the second thing to do for a baby, a child, to grow properly. I actually jumped one because before establishing hard diet comes breastfeeding. We will talk a little bit more about breastfeeding, but it's one very good preventative thing to do in terms of establishing proper growth and avoiding the need for further treatment. Not the only thing though, because after breastfeeding again comes hard diet. Mm-hmm. Hard diet will lead to continued exercising of the muscles that will drive proper craniofacial growth. Um, Also, doing early assessment regarding possible oral ties, such as tongue ties, buccal ties, lip ties, that it could hinder development as well. That combination of nasal breathing, proper diet, coming from breastfeeding, will probably ensure that the kid will have proper oral myofunctional habits that will most often lead to proper development.
Uh, Thank you, doctor. And if you don't mind me asking, I see a ring on your finger. I see that you're married. Do you have children yourself?
I do. I do have two daughters, and we learn so much by being parents because you develop empathy with your patients in learning what is doable, what is feasible, because we learn so many things in academia, but not all. Some things are easier said than done, for sure, such as diet, for example. I come from Brazil, where I had much easier access to natural food. So establishing this hard diet and low sugar diet it's definitely much easier when you have access to fresh produce and meat and everything. Coming to North America in the last years, it has been a challenge doing this myself as a parent and also maintaining that suggestion for patients. Patients will simply ask, how can I do it? And that's truly a problem.
Mm-hmm, mm-hmm. Yes, I am also a parent of two daughters, so we have that in common. And before I had children, all of the things you said, I knew in my head. But what I realized once my first daughter was born, my second daughter is still in her mother's womb. She'll be born in March. Well, what I realized was it's much easier said than done. So, for example, very quickly I realized it's not about breastfeeding or not breastfeeding. It's a question of how much breastfeeding, because it's not all or nothing. You can breastfeed some of the time, not breastfeed some of the time, or it's not black and white. And so what I noticed was that anytime breastfeeding was happening, nasal breathing was also happening. So it seemed to me like breastfeeding was nature's design to promote nasal breathing. It seemed like an integrated thing.
Yes.
However, anytime breastfeeding was not happening, it seemed like there was an entropy that led straight to mouth breathing. It's almost like as soon as you remove the breastfeeding, the mouth breathing happens naturally, like for who knows what reason, maybe environmental allergens and whatnot. How much breastfeeding do you think is required in order to override the natural entropy that leads to mouth breathing in an infant? Is it a matter of duration, like 2.5 years would be an arbitrary number? Or would it be a matter of, 1 year, but full time? What's your opinion on the amount of breastfeeding that's required?
Sure. I wouldn't say that I'm no lactation consultant myself, but we learn, we study, because this creates the problems we try to solve later in life. So that's a topic that we do study and learn about. So for most of the research available, would say that exclusive 6 months of breastfeeding in the beginning, that would be the minimum. Mm-hmm. And baby-led weaning is what most advise. It will vary. One thing that we common misunderstand about breastfeeding is that it is simply the start, the kickstart to facial development, but it doesn't ensure what happens next, because muscles need continuous stimulation. One good analogy that you can have is, for example, you can go to the gym, you can start a new exercise routine. You can, like say, you go to the gym and work out for a whole year. You will build up some muscles, you develop, you get leaner, you get fit, but then you get a cold and you spend the next 2-3 weeks and you miss all the exercise and you spend that time in the couch. You will lose. You will lose what you've built. It doesn't go back to beginning, but you simply cannot maintain. It's the same thing with breastfeeding. If you do 6 months of exclusive breastfeeding, it's fine for that moment. But if later you develop any type of breathing congestion such due to an infection or allergy or whatever reason, this will jeopardize everything you built so far. So it's not something that I did this 6 months or I did even 2 years and it's good for life. Mm-hmm. It's a combination, but it's definitely the right way to begin. And you mentioned something important. Our species in this planet are dealing with many things that we were never prepared to deal with environmentally. So we breathe the air that is polluted with so many different things that have never existed for our species before. So our body is literally trying to survive and adapt to many things that we were never exposed to. And many of these compensations are new. We don't have like definitive answers for most of those questions, but we have ideas, and the ideas would be try to mimic nature, try to do what have worked for the past 200,000 years. So if it has worked so far, why change?
Mm-hmm. Mm-hmm. And how did you deal with the fear of your children choking when you tried introducing them to hard foods at a young age?
You need to control the portion size, and babies do know it should be supervised for sure. If you give, like, for example, a carrot, they will not be able to just break it and try to swallow a huge amount that would cause choking. They are just scraping the food. They are exercising the muscles. The texture is very important, not only the nutritional factor of the food, but the texture as well. We want to provide exercise. So this could lead to another question. For example, the use of pacifiers, soothers, a thing. Instead of that, try to use things that would mimic natural exercise, such as chewing shoes and those chewing necklace, things that would promote good exercise, instead of non-nutritive, what was called non-nutritive suction habits that will cause the wrong muscles to be highly exercised, that it would develop more than the muscles that you need to have in place. It simply causes imbalance in facial development. That's the benefit of raw food. And if it's raw, if it's hard, most babies will simply, due to the domestication process, they will self-regulate the amount of food that they will be. Problem usually happen when it's too easy. When it's too soft, too mushy, too easy, they will simply eat more than they can handle because they are swallowing much more rapidly than they would. So harder foods make it even more difficult to cause any swallowing problem.
You mentioned a raw carrot stick. Do you have any other baby-led weaning favorite foods that worked in your family?
Meat from bone, something like ribs, and chicken wings might be trickier because there are some minor bones that can break. But I'd say meat, some kinds of fruits that they can also try and play with it. The more movements the baby needs to do in order to acquire the food, the better. The easier you make it, if you scrape, if you open, if you slice, everything you processed previously will make it easier, will make it the calorie intake being higher than the baby actually needs.
That's really good insight. And meat ribs for me as well has been a favorite in our household for our daughter. So we share that too. Now, you come from Brazil. You're in Canada now, but you're originally from Brazil. And my understanding is that Brazil has a reputation for being very breastfeeding positive. Yes. Can you tell us more about the Brazilian culture around breastfeeding?
Yes. So, yes, Brazil is indeed, I'll say, this is not a controversy in Brazil, breastfeeding. It might be a historical factor because we have a large influence from indigenous population, where up to this day, breastfeeding is the primary method of infant feeding. And this has been probably passed through generations and it's always been considered normal and the right way to do. and it's considered like an essential part of motherhood. So it doesn't cause any awkward perception of it. But not only the historical factors, cultural beliefs, but I would say some public health policies as well, such as maternal leave. There are many public health campaigns that are promoted on television and magazines everywhere. So we grow up being exposed and learning that that's natural, that's the right way to do it. It's part of being a family and a mother more specifically. And also fathers are encouraged to provide support. I would add that economical factors as well, because I would say that a large part of our population don't have proper access to formulas and other nutrition for babies. It's simply more expensive, out of reach for many. So they are lead with what nature intends us to do. So it's never been a problem for us.
Mm.
Curiously, it doesn't lead to Brazil being less exposed to malocclusion and to other craniofacial growth problem, sleep and breathing disorders as well. So as I'm saying, I'm not trying to discourage or diminish the value of breastfeeding. Quite the opposite. It's the proper way to start to begin. But unfortunately, it's just that. It's just the start. Everything else matters as well. Because we do have very solid research showing breastfeed as a preventative method for malocclusion. Population-wise, children who were breastfed show display lower rates of malocclusion. It has been published and published and published again. But in a broader view, as a country-wide, for example, Brazil being positive, which is something that we could agree on, does not translate to a whole country being producing better faces or better development in general because of everything else. Because we leave breastfeeding and now we are exposed to ultra-processed food the same way as everywhere else. And then that's where the problems begin.
So in Brazil, the problem occurs at the handoff from the breastfeeding to the baby-led weaning.
I would say so.
And maybe in the United States, the problem is both. Generally speaking, it's not much breastfeeding and then directly into soft, mushy foods.
Yes.
So, but would you say Brazil is any better in general when it comes to facial structure? I feel like the country does have a reputation for beauty. Some of that has to do, I think, with skin complexion and certain features. I mean, you're a handsome guy.
So thank you, you as well. But we have a very mixed population. So one thing that we, coming from Canada, some of my new friends or people we meet, they say, "Oh, you don't look like Brazilian." And I said, "Is there a Brazilian look? Is there anyway?" Because we look like everything. We could have traits like Asian. We have a high Asian immigration. We have a large African American population as well. We have indigenous. We have everything. So there is no such thing as like a Brazilian face, because it could be anything, any type of skin, any type of phenotype, everything, which is, I think, something very, very positive about us. And another thing would say that Brazil is number one in facial surgeries. And so aesthetics is in high demand, and people would do like crazy thing to get that a little bit to the extreme side. So there is this cultural pressure in terms of looks and cosmetic thing. So if you are not in that norm, and this is not positive at all, but it does produce, at least being foreigner looking back to Brazil, what Brazil exports, it's the best, I would say, or what we have, but we do have everything. I wouldn't say that this is representative of everything. I don't believe that we differ that much from everywhere else.
Yeah, that's fair.
But from my perspective, being an orthodontist, I would say that we are yes, exposed to different beliefs, are not so mechanically driven as most North American doctors are. So we, as not only as a community, but a healthcare community, orthodontics more specifically, we are more acceptive of different techniques and different things. So we do pay more attention to facial development, to early intervention, and things like this.
It almost seems like the Russian culture around health and dentistry. It seems to be more open. A lot of the MARPI providers, for example, are from Russia or Ukraine. And like, for example, Dr. Lipkin, where we met at Dr. Lipkin's office, and Mariana Evans, Lena Sapoznikov, and others. There's maybe Brazil is like Russia in that there's an open-mindedness to the health system there.
Yes. And maybe more general health care-wise, in a way that we should understand the causes of the issues we are trying to treat, not only addressing the symptoms. And it is something that I wouldn't say I learned. It's widespread, but it's stronger. That idea of deal with the cause of the issue rather than just the symptoms. I would say that it's more widespread in Brazil.
Now, you mentioned that Brazil has a high affinity for cosmetic enhancement.
Yes.
Is there also an interest in jaw reconstructive surgery around cosmetics in Brazil, or is it mostly more superficial stuff?
Most plastic surgery, not even that, most, they call it facial harmonization. It's basically fillers and Botox and things like this. Dentists in Brazil, in my opinion, are forgetting what they need to do, and just they found that niche that they allowed. Most dentists, not most, but a large amount of dentists in Brazil deal with this facial enhancement, which again, I am not against at all. But most of those enhancements are applied on top of unhealthy individuals. You don't treat the cause. You don't understand what led you to that situation. You do something temporary that provides good results, but within a few months you lose it, and then you become addicted to that result, and you keep doing things with your body that are not healthy on the long run. Instead
for example,
yes,
right, and to enhance the jawline, instead of doing a jaw surgery, which would also address the airway in addition to the cosmetics, they would be more likely to just fill the ramus with an implant or a filler to make it look sharper.
Yes. In terms of sheer amount of cases, that's the most common approach. Yeah.
Yeah, I think in America, this is the case as well, where people don't realize that a lot of the cosmetic enhancement that they're looking for is really in the bone structure rather than in the soft tissue, and that the soft tissue changes when you change the bone structure that's underneath it. But of course, jaw surgeries are major procedures that can have big consequences. And so naturally, it's not going to be a first option for someone.
Yeah.
So I want to transition to your real expertise, which is intercepting when a child is going down a bad path in terms of their development. And this is every parent's nightmare, and probably the norm in terms of what people encounter as parents. They intend for their children to have a great foundation and a great start, to be nasal breathers, to have a big palate, to sleep perfect, to never get infection in the ears and need antibiotics, and to be this perfect little myofunctional baby. But that's rarely the case. And so what signs can a parent detect to know that interception is needed? At what age is it appropriate to intercept? And what does that interception look like?
Okay. So you are touching some factors here. The most obvious and detrimental one would certainly be the mouth breathing habit, which is a huge debate in itself. Is it a habit? Is it a necessity? Do children and people in general breathe through the mouth because they are just used to do it? Or is it a must? They need to do it because they can't do it otherwise. I would say there is a little bit of both. but that's another topic. We can come back to this. But mouth breathing, just observing a child breathing through the mouth, that's a huge red flag. Next one would be sleep habits, including snoring. Snoring is an indication that you have a turbulence, that you have less than ideal space for airways, and that's a sign of concern. You shouldn't ignore. That's not something that you grow out of it. Those issues tend to become worse. So it's never normal, never okay. This is not something that will just improve on its own. It requires some type of intervention. So mouth breathing, that will lead to improper oral posture. How can you see early signs of incorrect oral posture? The incompetent lips. If a child at rest cannot keep the lips together without any type of effort, that's a sign of an myofunctional imbalance. Proper resting posture is the lips are together at rest with no effort of the surrounding muscle. There should be no strain on the chin, no strain on the cheeks, nothing else used in order to keep the lips together. So child is resting, should be breathing through the nose, lips are together. So open lip posture is another red flag. Tongue thrust. If the child is swallowing, eating, or drinking anything, and during swallow, they're moving, thrusting the tongue forward, and you can see it past the lips, or when the child is smiling, and you can see that tongue either resting lower or in between the teeth and thrusting forward. This is also a sign of myofunctional imbalance that will lead to changes in how the face is developing. Presence of allergies that could lead to nasal congestion, leading to mouth breathing. Prolonged use of pacifiers or thumb sucking. This will also create problems regarding oral posture. Speech problems as well. So if a child is starting to speak and you see some presence of a lisp or any type of alteration, this could warrant an observation too, because this could be indication of improper development as well. So I guess that would be all. Breathing, oral resting posture, nasal congestion. Any problems with chewing and swallowing also could be indications of reasons why to seek care for your child. You also asked when to intervene. It depends on what the problem is, but when to intervene is at birth. I would say that even before birth, by providing proper information, educating the family on what to look for and what is the best thing to implement to avoid those issues to ever come to fruition. But an assessment at birth for the presence of tongue ties, for example, this is another thing that happens in Brazil quite frequently. It's past part of public policies. So on every hospital, they do this type of assessment. When needed, they will refer for the myofunctional therapies to a pediatrician, a dentist who will do the release. So that's something that needs to be observed as well. Observation of cranial strains and postural adaptations that could need a body worker such as an osteopath or a cranial therapy. That's something that should also be observed too. Regarding myofunctional therapy specifically, most cases typically will only begin treatment usually after 2, because the child must understand a little bit of what the training and exercise that needs to be done. So it takes a lot of parent involvement, obviously, but most traditional myofunctional therapy would start at around 2 or even later. But even before that, as I just said, there are things to look for.
So my daughter is 14 months. So she's in that tough spot where she's not really old enough for you to give her instructions,
Yes.
but she's also very much on a growth trajectory. And sometimes her habits are not perfect by any means. And I think it's definitely not that she's always mouth breathing, but sometimes she's mouth breathing. For example, in the wintertime, it's 12 degrees outside Fahrenheit right now, which is frigid, and the air is extremely dry. The humidity it's 30% here in my house, which is low. And so her nose gets stuffed up.
Yes.
What can you do about like a toddler, a 14-month-old, to get them to be better? It's very difficult.
Yes. Nasal hygiene is very important. So compensate for that lack of humidity. So there are those neti pot solutions and other type of sprays that you do nasal hygiene. It works. It's a very common advice you get from pediatric ENTs. Making this a habit. Having some games or creating some myofunctional exercise that you can have with the chewy tubes and other funny movements. Everything that you create will improve range of motion and strengthen with facial exercise is also helpful to establish proper lip seal. One common thing you will find online, but we have some reservations towards it, would be mouth taping. I use mouth taping as a tool especially in very young child, that can only happen while supervised. During the day, the child's awake, parents are watching, and it's a game. They're playing a game for an amount of time. It is just a small segment, keep it just as a reminder to keep the lips together rather than wrapping your face around and shooting the mouth closed, because you could lead the child to an increased stress if there is a presence of any type of nasal obstruction. This is not help. You will not correct a nasal obstruction by closing your mouth. So if this is a constant habit, an evaluation with a pediatric ENT is always helpful. They will do, they have their means to assess if there is any type of obstruction that can help. It could be due to diet. It could be to other type of allergens creating that obstruction. Not every consult with an ENT will lead to surgery. Very few of them will, actually. So don't fear, not yourself, because you're very highly educated, but most of your public, don't fear going to ENT. Please do it. You will learn many insightful tips and tricks to just coordinate your child and help preventing those habits.
Yeah. Thank you. And just to clarify your position about mouth taping in very young children, it absolutely cannot be done when they're trying to sleep. Is that right? Because this could lead to sudden infant death syndrome potentially. You don't want to hinder your child's breathing at all when they're asleep. This is only when they're awake and they're being monitored, and it's more of a game to teach them what it's like to have their mouth closed, but it's by no means forcing nasal breathing. Is that correct?
Exactly. I couldn't say it better myself. That's it.
And do you think that SIDS, sudden infant death syndrome, this phenomenon where parents wake up and God forbid they go in to check on their child and all of a sudden the child is deceased and no one knows what happened. Do you think that SIDS can often have something to do with sleep disordered breathing?
It can. It's a combination of many things. Swallowing reflexes, tongue ties have been associated with it because it keeps the tongue in a lowered position. That would be something that, again, you could notice while breastfeeding, if the child can develop a proper latch or not. If they have gases and colics, that would be an indication of that they are swallowing air while they're trying to feed. This abdominal discomfort could be an indication of it as well. So pay attention to any type of abnormality. So as you said, it doesn't lead to something as dramatic as that situation. So there are signs that would prevent it. So very, very rarely it's something that happens with any hint. So it's a build-up of situation that will lead to that. It's not something that happens like immediately.
And in terms of this question of identifying if your child does have sleep disordered breathing and, for example, catching them snoring,
yes,
how can you know if your child is snoring if they're sleeping in the other room?
That's another cultural thing. For us coming again from Brazil, it's very, very common that would happen with the child in the same room.
That's what I'm getting at.
Yes.
There's this big push to
common.
keep the baby in a separate room in America.
Yes. I'm not so sure if I have my formed solid opinion on it, because I do understand the need to create independence. That's something I've been in Canada for the past 3 years. And we learn in terms of this cultural adaptation a lot, such as our kids going along to school and just getting the bus and moving. We were used to just drive them everywhere. And kids in general, they are much more independent, which is a very good thing. But sometimes it's too much. So do you really need your baby to be in another room? I'm not so sure.
Yeah. And just one very practical consideration there is, if your baby is in the same room with you, it allows you to detect if there's something weird happening with their breathing at nighttime. Yeah. And it's a way that you can get one of these hints that you're telling us about that builds up to something more nefarious developing over the long term with the child.
But it ties with many different situations. For example, as I said, maternity leave. Most mothers in Brazil are not concerned to lose 1 or 2 nights of sleep because they are not pressured to come back to work immediately. And they are allowed to take the time to live that experience to the fullest. And it's common. It's not something that they would struggle on developing.
Yeah. No, you're touching upon an extremely important point, a very controversial point, which is the sociological economic aspect of facial underdevelopment, which has to do with really women who are the ones that are anatomically capable of breastfeeding and nursing a child being so deep in the workforce and feeling this tension to get back to career instead of sacrificing night's sleep or time during the day to breastfeed to give their child an opportunity to have proper development. And I'm not blaming women, of course not. And many women are working because they have to, but that also doesn't change the fact that there is an inherent tension between mother participation in the workforce and child's need for access to his mother's body in the first months and years of life.
Yes.
And is there a solution? I don't know, but extended maternal leave is certainly a good place to start. I think one goal for a man would be to create a financial situation for his wife and his child to give them both the opportunity to be together most of the time, especially during infancy. So that could be a real noble financial goal for a man to have, to be able to.
I definitely agree. Ultimately, this is entirely the mother's decision on how to coordinate all of this. But being in that position, I think that the only thing we can do is support and provide the best environment for that to happen, for them to have the true choice. So it needs to be a choice. It doesn't need to be, I need to do this because I don't have other way around. So we would need to provide a choice. I agree.
Yes. So what about dental intervention, the types of treatments that you do? When do those become appropriate for a child? Age 4, age 5? I'll let you take it away.
Good. So it's been for me a lifelong learning process in unlearning some myth that we are exposed throughout dental school, and as we are exposed to more to current research, and we never stop learning. I was trained as a traditional orthodontist. There would be this ideal age for proper orthodontic intervention would be close to puberty, because of that pubertal spurt that kids are growing faster, and you need to take advantage of that time because more rapid changes might be happening in that way. And that is simply false, because we don't treat our patients to become any taller. We treat their faces, and facial development happens much earlier than the rest of the body. By the age of four, Girls have around 78% of their face the size of the adult, and boys have 73 by the age of 4. So most of the face is fully developed by the age of 4. It decreases in speed after 4. By 7, 8, it's around 85% of the final dimensions of the face. And if we are trying to do something to ensure that that individual would express the proper growth, that intervention must happen again since birth. Even dental interventions. There is one appliance called muscle memory palatal plate. It was initially developed for Down syndrome babies. Down syndrome, one of the things that Down syndrome would cause is low muscle tone. Kids with Down syndrome, they have the droopy face, the tongue is enlarged, partly because the rest of the jaws are not growing properly, so the relative size of the tongue tends to be bigger, but it definitely has a problem with muscle tone. So the earlier you encourage that baby to establish proper posture and muscle activity, the better results you get. But not only Down syndrome, other babies that were exposed to tongue ties, for example, how would they learn that there is such thing as a proper resting position? We mentioned hard diet and breastfeeding, but from a dental perspective, dental approach, there is this appliance called, again, the muscle memory palate plate. It looks like an Essex retainer that is the shape of the whole mouth, including the palate. It sits on the upper arch, and that plate has some holes and buttons that encourage the tongue to move to a certain position. And it doesn't have, as the baby at this stage has no teeth at all, it's purely support on soft tissue, and it needs the tongue to hold it in position. So it encourages the tongue to move to a better position. You could do palatal expansion as early as 1.5 as 2 years, 18 months, 2 years old. You can already do palatal expansion when needed. When the child is falling behind in terms of growth, why wait for the problem to become worse? We are used to do early intervention for anything. Let's say if a child goes to an optometrist, eye doctor, and for some reason they have any vision impairment, will they wait until they get to do school tests or driving tests or whatever to use some corrective lenses? No, they will do right away. You need to restore the function of that organ as soon as possible. It should be the same with the mouth. If the mouth is not growing for whatever reason, deal with the cause, remove the obstacles. But if it's falling behind, so let's say at that age, the normal dimensions for intermolar width would be that, and the kid is not at that rate, you should help it. You should address that issue. You should create opportunities for them to develop properly. So
what would a palate expander in an 18-month-old look like?
It is just that if you have any teeth at all, you could use some clasp around it, but most of it is just the acrylic plate over the teeth with the screw in the middle. There are some that are spring-loaded, so you don't even require the activation screw. So it just sits there. It's supported on on soft palate. Remember that at that stage, most of the sutures are highly, highly flexible. Mm-hmm. So you don't need the amount of support and amount of pressure you need in older patients.
What does the mandible do if in a child that's under 2 years old, and in any child for that matter, when you start splitting the mid-palatal suture, how does the mandible respond? Does it grow around it, or do you end up in a class 2 or in a big, discrepancy?
That's a very good question. I believe that this is a missing link between this early intervention, because sometimes we don't account for everything else. Palatal expansion is a huge thing in terms of restoring growth, but again, as you said, is primarily just addressing upper jaw. While doing palatal expansion, the maxilla will open not only transversely, but it opens like in a triangular shape. So it moves forward and downwards as well.
Just
So
like with
usually,
Marpy in an adult.
yes, the same thing.
Yes.
It is even easier and more pronounced as young as you are.
Mhm.
The younger you are, the more everything else in the face will follow that stimulation and grow accordingly. So now you have your palate descending, your maxilla moving forward, and also becoming wider, which creates an opportunity for the lower jaw to rotate forward, to close, and to move, to simply displace more forwardly. This does not mean that it will happen automatically. It simply creates a better condition for the lower jaw to be like unlocked and assume that position. It will only take place if properly trained. We can do this with myofunctional therapy. There are certain intraoral appliances called myofunctional orthodontic devices that can help establishing proper rest position for the lower jaw as well. Sometimes, depending if you don't need that amount of expansion, if it's not too much behind, you can still stimulate proper growth by just addressing the breathing and proper tongue resting posture. So sometimes a single appliance can take care of both upper and lower jaws.
In a child, when you give them palatal expansion, is it like when you use Marpy in an adult? Does their nasal breathing improve too?
Yes. And again, everything that you do in an adult happens quicker, happens more pronounced, and has more stability in a younger child.
Did your children have any palatal expansion at very young ages?
Yes. My older one just used a myobrace, which is a pre-made myofunctional appliance. That's the only thing she had since ever. But my
How old was
younger,
she? How old was she when she got
she
that?
was 2.5 when she
Wow.
first started. And the older one, she needed everything. So she had a tongue tie. So she had a tongue tie release. She did myofunctional therapy. She did a lip tie as well. She had expanders and the myofunctional appliance as well, the myobrace too. The younger is now 12, and I can show them here.
Yes. You want me to put the screen share on?
If you allow me a couple of minutes, because I didn't have them prepared.
Oh, yes.
Show, but I can very quickly find.
Yes, by all means. And these are your daughters that you're going to show us?
Yes.
Oh,
Yes.
I'm very curious.
I have all the cases, but let me show them really quickly.
Mm-hmm.
They can showcase the treatment.
Yes, this is the big question for me is because I see my daughter, she's developing okay, but it's far from perfect. And I really don't want her to struggle with her cognitive functioning, with her sleep, or with her aesthetics throughout her childhood, because I think, girls really have a hard time with that, especially. Boys do too, but I just want the best for my daughter, and I want to make sure I don't miss any windows of opportunity to get involved and give her a nice boost to her nasal breathing, to her jaw structure, to her development.
Yes.
So my daughter, like I said, is 14 months, and I'm reaching that point where I need to make a decision about what type of intervention to look for, who to see about that, and what I can expect that to do for her. And I've been told sometimes you need multiple expanders over the period of the child's, growing up. Maybe you need 2-3 expanders, not just one. And so I'm really working hard to get this right for my child.
Sure. What I would say, even before, so there's not an opinion specifically for your daughter. I have never seen her, but just in general, we do palatal expansion quite frequently because most patients come to us when they are already behind. So they should be at that stage in development, but for whatever reason, they are not. So palatal expansion would be catching up to what should have happened and didn't. So we're taking care of the past. So we do expand, we mechanically expand and create the space that should be there since always. When we do that, we simply restore them to that stage. after palatal expansion, if you follow the mechanical expansion with proper training, with proper myofunctional training, now you have the proper anatomy, and you put that mouth to proper work. So you get the muscles to work. You get the tongue to be the retainer. Because that's a problem. So there used to be more controversy around palatal expansion, because most older studies would show, you know what, there is not enough stability. You can do whatever expansion you want in mixed dentition. When that patient grows into permanent dentition, that expansion is lost, and you need to just restart and do everything over again. So why bother? Why bother with doing something if you need to retreat that patient again? The problem is, if you do the expansion which is needed, because again, it's not about aligning teeth, it's about creating proper airways, proper viable and patent airways. So I'm sorry about that. My camera just fell.
It's okay.
This will be...
No problem at all.
Just finding a better position for it so it doesn't sit on top of the monitor.
You're proposing a mental framework of thinking about expansion in children in terms of airway, not in terms of occlusion, which is unorthodox.
Definitely. Yes.
And are you the point that you're getting at, and I only maybe try to finish it for you because you were interrupted by the camera falling. Are you getting at the missing link in the old studies is not introducing myofunctional therapy after expansion?
Yes. So you create an anatomy that is unsupported by function. Mm-hmm. You create a dimension on your arch, and then you have nothing to hold that dimension. You have cheek muscles, you have open lip posture that simply cannot hold that new dimension you created, and you have nothing inside because the tongue is still low. Mm-hmm. So you resort back to retainers. But what is retainers a good thing to do in a growing child? How can you retain a growing child? So if you do an expansion in a 6-year-old, for example, 4, whatever, so and you do 6 months, you develop, you got a very good result. What do you do after that? If you keep that result, if you have a retainer for a longer period, you are impacting their ability to erupt new teeth. And that dimension that is good for when a child is 6, it's not enough when it's 7, 8. It needs to continue to grow. And you're not expanding a 5-year-old to have the final size for permanent dentition. That child is still expected to grow naturally. So what is natural growth? Natural growth is the establishment of nasal breathing, tongue resting position, chewing, and proper swallowing habits. So expand, good. Most of them will need that. But if you don't follow this with restoring function, you will have trouble maintaining that expansion.
Yes. An analogy I thought of when you're talking is when you expand in a child, it's like during a Formula One race where you have a pit stop and you change the tires, but then the race keeps going, right? Yeah. So that's what it's like with a child. You're just you're getting them so that they can keep going and keep growing, but you're not actually fixing them. Whereas with an adult like me or you, who both have had MARPE and expansion, it's more like the final tune-up, and then you park the car in the garage for good. But with a child, it's just a pit stop. And so but also, again, this is just like with adults. You can't expand an adult or do a jaw surgery on an adult and then have no functional improvement through myofunctional therapy, et cetera. Yes. You're going to get relapse.
Yes, definitely. It has been shown. That's results show this. This should not be like anything new. If you have a knee surgery, if you have some problem with your knee, get a new surgery, you are expected to do physiotherapy after that. It's common sense. That why this is not the case with the face. So if you change anything, you still need to learn how to use your new organ, your new mouth, your new chewing device. You still need to learn how to use it.
Yes. Well, I think the reason that conventional medicine doesn't treat the face like it treats the recovery of the knee is because conventional medicine doesn't accept the fact that there's a certain normal function for the face in the first place. They don't even acknowledge that poor function, poor and bad environmental conditioning can lead to facial
Yeah.
deformity or facial
Absolutely.
underdevelopment in the first place.
Absolutely.
So there's a disconnect.
We learned that it's purely genetics. There is nothing you can do about it. You are born this way. You are condemned to do, and you can only do minor compensations. You move the teeth around. You have lots of limitation, and that's it.
Right. Wow. Do you have those slides loaded up, Doctor?
So let me show you. First one, my daughter. This is my product. My view. I am completely biased with this case. But what I want to highlight here is you see proper facial development, proper symmetry on the facial thirds.
Very nice profile.
A predominance of forward growth.
Very, very nice profile.
We like the mandible plane angle. We like facial profile, the full lips and everything. And I can assure you this is not simply due to genetics. Both my wife and me, we were orthodontic patients. I have a whole history. I currently have a MARPI myself, which is another story. So this is not because she inherited good genes. I had all the problems you can think of. My wife is a patient as well. So we helped her since the beginning. She had a very deep bite, a severe class 2 when she was really young. We did palatal expansion, and she grew up using a myobrace appliance for many years. She's still up to this day. We'll go to bed. There is one last thing we try to improve, which is lip resting posture. Watching, because again, we are highly picky, I would say, with her. So I'm always watching for possible problems. And she would, when she is distracted, learning doing something, she will rest with her lips still open a little bit. So we are continuing doing exercise with her. So what I want to show you is that she had palatal expansion just with removable appliances. She didn't need any Hyrex, Harcype, it was just removable.
At what age, Doctor? Did she?
The expansion was done when she was 7. She is now 12. Expansion was done when she was 7.
She had no intervention before the age of 7? Myofunctional or expansion? She
had a myobrace appliance, but she was between probably 5 and 6. She was not the most cooperative patient because she was not a patient. She was my daughter, and she would take pleasure in doing exactly the opposite of what I was trying to.
Father's curse.
Yes. Sometimes doing courses, we always have colleagues bringing their own kids' case, and I beg them, please don't start learning this, practice this with your own child, because they will be your most difficult patients ever. So don't practice on your own. But she did very well after the tongue tie release, which was late because it didn't cause any speech impairment. I was still learning better, and it only became obvious when we were struggling with this. She would struggle keeping appliance into her mouth. She would struggle moving the tongue to a better position. So we did proper assessment, proper evaluation. That's when we decided to do the tongue tie release. And after that, she flourished.
Do you have any before photos of what she looked like as a younger child? I
do. So this is her at probably 2.5 to 3 years old. That's what I want to show. So she had this in between tongue resting position, a class 2 deep bite. The arch was never too bad, but because of the tie, she didn't grow up maintaining that position. So not too bad to begin with, but if you look at facial profile, you can see the genes falling behind a little bit. Not the most severe case. I have treated some more discrepant patients, I would say. But
so if we do look at the profile,
yes.
You say not the best, but not the worst. I would definitely agree. Certainly not the worst. But when we do look at it objectively, what are we looking at here? A little bit of the double chin forming underneath.
The double chin could be an indication of underdeveloped lower jaw. You see this mental labial angle here. showing a little bit of an increased fold on her lower lip, which is an indicative that she is biting down. Her lower lip is touching against her upper teeth, and it starts to revert back like this here, which when we look inside, we corroborate this by identifying the deep bite and the retruded lower jaw. Again, not the biggest overjet we've ever seen, obviously. But what I want to highlight in her case is that we did get to a final result when facial development, arch development, everything is very acceptable. But we still have something that eventually will need some addressing, which shows a little bit of limitations on this functional approach, which is, although she had all the space in the world in her arch, both upper canines, they both erupted with a little bit of rotation. They are in proper angulation, but they are both rotated. And when you look in a frontal view, they don't show up correctly. And she's now starting to be bothered by this, and now it's a cosmetic issue. But what I want to say is that doing any type of adjustment now would require a very simple, gentle, quick and easy fix, probably just aligners, to close some of those gaps, rotate those teeth, and establish a proper occlusion. It's a much, much easier orthodontic, minimally invasive orthodontic case here, where you already have the face properly developed. We are not using orthodontics to accomplish any type of facial change because she doesn't need that. So if I can show other cases.
So the difference is you're using orthodontics now just to shift teeth laterally within the alveolar bone, rather than trying to blow the teeth out in the alveolar bone to create oral volume.
Absolutely.
Which is, I would argue, not ever ideal, whether it's a child or an adult. You don't ever want to push outward on the teeth if you don't have to.
No, I love orthodontics, but when it's done for what's designed for, which is improve teeth positioning, doing fine-tuning. Fine-tuning is what orthodontics is best at, not at addressing everything else.
And at some point, I want to ask you about, at what age does MARPI become appropriate for a child? Because the skeletal work wasn't done early enough, and now the choice is between dental expansion or tooth-anchored expansion, let's call it, versus skeletal-anchored expansion. And I know that's a big debate, and some people say that 10 years old is the cutoff, but some people, I think, would argue that MARPI could be appropriate in an even younger person. And so maybe you can opine on that at some point too. Maybe now you can just offer your opinion.
Sure. Can I share this slide with you?
Absolutely.
So this is a work from Dr. Audrey Yoon, Dr. David Gozal, and other collaborators. This was published in 2023. It's called A Roadmap for Craniofacial Growth and Development for Healthy Airways. So that's what I like about this study. It's a literature review that put together basically all our knowledge regarding what can we do on every age range in order to ensure that the face is developing proper, so we can ensure that the airways are working.
Just to be clear, do you support this graphic 100%? Do you think that these are the correct numbers?
I do. I guess that this is the best thing we ever came up. This is so clear and so sound because it shows that it's not a single intervention that will take care of everything. It's everything. So it's not about doing just slow or rapid maxillary expansion. If you do this, you are taking care of the nasal maxillary complex. You still need to care about the mandible. You still need to pay attention to lymph tissues. You still need to pay attention to function. So it's everything. So when you do everything, when you take care about form and function, then you get proper results, stable results. And if you feel that either MARPI, is it MARPI the solution for everything? Absolutely not. My case, for example, I currently have a MARPI myself, because between 11 and 13 years old, I had braces myself and I wore a headgear, which put my maxilla back. I had a huge overjet with class 2, but my problem was never in the maxilla. My problem was an underdeveloped mandible. But they put back my maxilla. My occlusion is fine. I had never had any problem regarding teeth alignment, but I can breathe. My nose simply doesn't work because all my maxillary complex, instead of being helped, they were artificially constricted. So breathing was always an issue. So I have a MARPI myself. I had 8 millimeters of expansion, which helped me significantly establishing better nasal breathing. But as I still have my mandible, my underdeveloped mandible, I still wear my lip appliance that helps keeping my lower jaw in a better position, moving my tongue to now a much more comfortable position in the roof of my mouth. So MARP improved my nasal breathing, but I still have obstruction on my oropharynx. So it's not one single thing for everybody. It depends. Someone might have just a single problem on the maxilla, and if you do expansion, you solve everything. Beautiful. But you must pay attention to all of those aspects.
No doubt.
But
And
regarding your question, sorry.
Yes, I was going to say, for the people that are listening only through Spotify or Apple Podcasts that don't have the video, can you tell us in a nutshell? I know there's a lot happening in this graphic, but
Sure.
What is this telling us about dental versus skeletal expansion in children and adolescents?
It's basically showing that in growing children, there is no such need for dramatic skeletal expansion, because if you expand the arches to accommodate the tongue in the roof of the mouth, as the child is still growing, this will turn out to proper growth. When you do mechanical expansion, you are promoting growth at a increased speed. This is not the natural speed the body grows. You are doing a growth modification, artificial growth modification during a certain period of time, which is faster than the body naturally grows. In a child, that most facial structures are much more immature and flexible, they accept that stretch and that stimulation. There is no need to be harsh, to use like skeletal anchorage and doing very quick movements and rip everything apart. You are just creating unnecessary stress for the rest of the face. And remember that the goal would be creating space for the tongue. So you continue to develop. Don't stop there. So expansion in younger kids will turn out eventually to be skeletal, but every one of these approaches has been proven to be most dental alveolar expansion in growing children, which is not a problem in young patients because this is just unlocking their potential for growth. They continue to grow after that.
So am I interpreting this image correctly that we don't use TAD-assisted maxillary expansion, called here MARPI, until roughly age 12?
I would say that 10, if you see here 10, we could start considering, because you have increased the resistance at around age 10. So you start getting unwanted dental alveolar bending, much more pronounced dental compensation rather than skeletal expression for the expansion. So at that stage, you want to minimize the dental effects. You want to maximize the skeletal effect. So after 10, you should start considering skeletal anchorage.
So I misinterpreted the graphic. Then what it's saying is that around age 13, you must use MARPI. Is that what's being said here? That's what the red box is, as opposed to the black box above it?
Yes.
At age 10, it could go either way. You could use TADs, or you could try tooth-borne expansion, but starting at age 13, it's strongly recommended you use TADs.
Yes. So if you need to, let's say you're doing expansion primarily because you have crowding and you just want to solve like a dental problem, you can still have very good results just doing conventional expansion up until 13. Mm-hmm. But if you want to maximize the repercussion in the nasal maxillary complex, if you want your nasal breathing to expand because you are improving the floor of the nose, you should consider doing this after 10.
Understood. Thank you.
So I find this is a great aid to any practitioner in learning what our best research has shown to be stable and how to combine everything, with the primary goal again being restoration of proper breathing. This is not like what you do mechanically to solve any type of malocclusion. That's a
Understood.
different approach. But malocclusion will be less of a problem if you have everything else around it functioning properly.
Okay. Did you have more cases that you wanted to show us?
So I do. I have some interesting cases. Let me go back here to find them. Okay, so let me show this young guy here. So he's 3 years old. And another concept that we learn and we grow up simply accepting is that you have, because of genetics, you are born with your facial pattern, and there are some traits such as the facial profile that is innate and there's nothing you can do. So you are either born with, we call this dolichofacial patient, which means a predominance of the vertical dimension for growth. The face, instead of growing forward, grows more vertically. Mm-hmm. It could be a brachyfacial patient, which is the opposite, very short face. And ideal would be called the mesofacial, which is a proportion between the 3/3 on the face. So this boy, being 3 years old, you see a huge predominance of this lower third. See how much bigger his lower third is compared to the rest of his face. Mm-hmm. And you also can see the inclination of his mandible plane, showing that he is indeed growing divergent, and the face, instead of coming forward, it is definitely rotating downwards. Mm-hmm. This is not a good sign, because being in that situation so young, it means that throughout his life, this will only increase, because supposedly this is his facial profile and it can only be changed with jaw surgery whenever needed. But here's the case. He has an important open bite due to previous suction habits. That
pacifier?
Actually, it was a blanket in this particular case. He used to suck on the blanket. But the problem with sucking habits is that even when you're not doing this, thumb sucking, for example, pacifiers or whatever you are doing, is the tongue. The tongue will learn that space. And even when you don't have the thumb, the pacifier, or whatever, the tongue is still resting and is thrusting and occupying that space more often than the suction habit. So the suction habit simply creates a different muscle pattern, and this perpetuates the problem. Even when you remove the thing, if you stop some sucking, you still have your tongue on that position. It will not necessarily change automatically. Mm-hmm. Still needs to be trained. So this kid was treated with a myobrace at this age. Myobrace is a pre-made appliance. It's called a myofunctional appliance because the primary goal here is to reestablish proper breathing, nasal breathing, tongue resting position, and swallowing habits. It's made of silicone, it's flexible. It has lots of advantages and some limitations as well. Advantage would be it's easily accessible. It's easy to understand how it works and to prescribe. It is not the perfect solution for everything. It's a compliance-based treatment. It's something that the kids must wear for 1 hour during the day and while they sleep. It's another thing, as we discussed in the beginning, that is easier said than done. They always love in the beginning. It seems to be so easy. It's just 1 hour during the day. It's just when you go to bed. But putting that into effect, making that happen, associate the passive training, because we understand appliance to be a passive form of myofunctional therapy, because the kids are not necessarily aware of what they're doing, and most of it happens while they're sleeping anyway. So it's just a postural correction rather than exercise. You don't get to do exercise when you sleep, obviously. So you need to complement these with real active exercise to establish proper strengthening and stretching of your muscles to actually do the work. You must learn what is it that you need to correct. Anyways, he started with a myobrace at this age. He transitioned throughout the season, and within a couple of months, less than a year, you see the full closure of the open bite. his
That's
age,
incredible. That's
yes,
incredible.
his age plays a significant role here because, again, being young means that he still has most of his growth to happen. And as if you remove the offending factor and you replace it for proper muscle activity, you just allow the body to just continue to grow normally.
He's
Just
3 years old.
he was 3 in the beginning, yes. Uh, so he progressed. The good thing is, look at his face. He actually looks younger in the second picture because you see much less muscle activity. See that the cheeks are decreasing in size and his expression seems more calmer, more quieter than he was struggling because he was doing so much exercise. When you develop suction habits, your masseter muscles, they grow up so strong due to the continued exercise you do while suctioning. And you create this huge wall on your cheeks that prevents transversal growth from the jaws. And as you replace this for a proper tongue resting position and natural lip posture, the facial expression do change. But what I like most on this case is his mandible. Look at the inclination of the mandible plane. He was clearly growing downwards, and now he has restored the proper growth direction.
So what's happened here? Has the maxilla's angle changed and the mandible has just swung to meet it? Is that what's going on here?
Yes, both. As the tongue moves to the roof of the mouth, it redirects where the lower jaw is growing. So instead of it coming down, it restores the forward movement as well. And because he now can keep the mouth closed for a prolonged period of time, the dental alveolar complex, it simply stops growing downwards, or at least it slows down. So you get less of a vertical component, you get less rotation on the mandible, in more forward development. Mm-hmm. And it's stable. So he's not in treatment anymore at that second picture here. And you can see that throughout time, that correction that was done really early into his treatment is maintained, even after treatment completion. Treatment was finished here at the second picture, but you see that even without any type of retainer, any type of appliance at all, he continues to grow properly because the habits were corrected.
Wow, what a beautiful case.
So this is not a mechanical intervention, it's just treating the muscles to do what they need to do. But again, he was 3. So he still has much left in his growth potential. So he could recover from this. If you have a teenager in that situation, that's a whole different conversation. You still need to do the muscle training, but you're probably looking into doing some maxillary impaction, a more complex orthodontic approach to correct what is set, because it's permanent dentition, it's more solidified bones. It's not as easy to change just doing muscle intervention. But even if you do mechanics, you still need to train your muscles.
So this case speaks for itself. Now, tell us, how does the myobrace actually work? What's the mechanics that are happening inside of the child's mouth?
So let me show you this here. So what a myobrace does is, whatever improper habit you do, it could be the mouth breathing, lower tongue posture, retruded jaw, incompetent lip seal, whatever dysfunction is happening in the mouth, once you place a myobrace in your mouth, what it will do is direct the tongue to the roof of the mouth. It's loose. It's appliance that sits loose in the mouth. You place it on your upper jaw, and it indicates where you need to go with the lower jaw to close around it. So it has a channel for the upper and lower teeth in this ideal class 1 position. So you bring your lower jaw forward, most of the cases. In order to hold the appliance position, you need to move your tongue up to the roof of the mouth. And once the appliance is inside, it limits the amount of air that can come through the mouth. So it will redirect breathing through the nose. It will stimulate your tongue to sit in the roof of the mouth. And it will hold your lower jaw in this given position.
But how is it stimulating the tongue to come to the roof of the mouth? Because if it's not at the roof of the mouth, the appliance will fall out. So it's a game.
Exactly. So it has, they call it a tongue tag, which is a sensorial stimulation for the tip of the tongue. And if you don't do this, if you keep your lips open and relaxed, your tongue low, the appliance simply pops out. And it happens in the beginning of the treatment. You don't expect your patient within the first nights to sleep through the night with the appliance. They will simply fall asleep with the appliance. Eventually, they lose it. They get tired by holding the appliance in position. It's truly an exercise. That 1 hour that we expect patients to wear during the day is very important. I would say it's as important as the nighttime, because being awake means you know what's going on, you have continued stimulation, and you respond to that stimulation much better. So you are encouraged to pay attention to what's going on, develop your self-awareness, move your tongue to the proper position, keep your lips together. And it's a training. The more they do it, the better they become at doing that. And eventually, when they wake up in the morning, they would remove the appliance, but they hold that position through the day because it's now more comfortable and it feels more natural, this new posture that is being developed than the previous one. And once you change that posture and the more natural it becomes, eventually this translates to bone remodeling. So let me show you this other case that highlights another.
Is 3 the youngest for myobrace?
So they sell a device called Myo2, which is very similar to the Myomunchi. I don't know if you're familiar with a Myomunchi.
I've heard of it, but tell us how that basically works.
It's a myofunctional device that stimulates chewing, and it has some bristles inside that can be even used for infants, even newlyborns. They are very tiny appliance that they will probably, as if a chewing device.
Mm-hmm. Do you like it? Do you use it?
So I do use it, but as I don't typically see these very young children myself, because for most of my career, I work in conjunction with pediatric dentists. So I would refer those very, very young patients most of the time. So personally, I don't have too much experience with the very young ones. But I have tried on mine. I have colleagues that use. I had a couple of patients myself, and it's a mixed result. Some of them will love it. The kid will get attached to that thing. They will like it and start playing with it. And many will not bother with it. They will not even get it at all.
So the Myomunchi is not training the tongue to come up to the roof of the mouth as directly as the myobrace. It's more of a chewing force load on the jaws.
Yes.
Okay.
That is true.
And so the myobrace is you like, to the original question, is 3 about as young as you can go with the myobrace?
With the traditional myobrace, I would say yes. It can fit in smaller mouths, but that kid it's very difficult to get that type of compliance for such a young kid.
Is it a custom appliance or is it like off the shelf?
It's off the shelf. They have different sizes. So the practitioner will basically choose the size. It needs a dentist to prescribe it because of the potential. So it could cause soft tissue damage. It is not causing like trauma, but it can be uncomfortable. So you need someone who is able to adjust it. You need the proper prescription. It's not something that you do on your own because you need to know what the exercise, what the goal is, and when it's okay and when it's not. So
when you say to adjust it, do you mean sometimes you need to cut it a little bit to make it fit better?
You do. That's the problem of being pre-made. It doesn't fit every single mouth. So it has the dimensions, but not necessarily the contour and the shape. So sometimes you do need to do some adjustments.
Do you think it would be better if it could be custom ordered to fit the patient's mouth using
absolutely.
a CBCT?
This is actually one of our projects is getting how to custom made these and eventually print those appliances.
And what's the problem with that? You don't want to do maybe you don't need a CBCT to order that. Maybe you can just do an oral scan.
It'll be done in an oral scan, but there are many patents on that, on some of those features, and more importantly, you need to find the right material too.
And the myobrace company is not interested in taking custom orders. They're kind of stuck in their ways.
Yeah, so they have this system which works very well. So I've been I wear as well. I have mine as my sleep appliance as well. They have
Your sleep appliance is a myobrace?
Yes, they have a range. It's called MyOSA. It's essentially a myobrace in an adult size. It does the same thing. what do you want from a sleep appliance? You want an appliance that can help holding your lower jaw in a more forward position, never in front of the upper, so you're not creating an anterior crossbite. You want an appliance that can help keeping your tongue in the proper position so it doesn't block your oropharynx. And you want an appliance that would block the air passage through the mouth. So it's essentially a myobrace. So it's a myobrace in an adult size. They label it MyOSA because it will be primarily designed to treat sleep disorders in adult patients. But
and it also has the tongue ticker?
The tongue features, the same features. Yes. And I do have, that could be another conversation if you want, how to address this in adult patients, because it is also very helpful for TMJ problems as well. Because you decompress the joints, you relax the muscles, you do everything when you breathe through your nose and you rest the tongue on the roof of the mouth, essentially. Yeah. So they have a comprehensive treatment system with many different appliances that they have one appliance for every situation. So I don't think they will need they don't feel the need to supply this individually custom-made device.
Okay.
Because you can find one appliance for most of every case.
Shall we look at this next case?
So, 13 years old. She had been previously treated orthodontic. So she had braces the day she came to me. She moved from a different city and she said, I'm done. I cannot go further. I have this brace for 2 years already. And she had bleeding. You see, the gums are not in great shape. And she said, can you just remove it? And I said, yes, let's make a deal here, if you try this. So let's start doing some postural training, because you can clearly see that she has good, well-aligned arches, but they simply don't meet. They don't belong to the same patient. She still has an important overjet, an underdeveloped mandible, and the teeth alignment is not enough. We still need to develop proper occlusion. But I would never treat this by extracting a premolar and retracting the upper jaw to fit the lower, because clearly you can see the problem here in the face is simply the lower jaw is not fully developed. Mm-hmm. So why create another problem instead of solve the problem you have? Amen. So she agreed with this. She said, I do anything so I can remove the brace. So she started that same day with a myobrace, a larger size that can fit her jaw and a permanent dentition, but it works much of the same way. So eventually in a couple of months, we got rid of that overjet. She got a very natural and proper development for the lower jaw by doing the same thing, which is practicing a better posture for the jaw, practicing tongue resting position. Initially, this is simply a matter of adjusting posture. You can have this more retruded position, and you do some stretching and exercise, and your lower jaw come forward, which is something that you can simply do for the picture. You move forward instantly. This is simply a muscle movement. But if you're able to maintain that new position for long enough, you actually create some tension on your condyles that will cause new bone apposition and remodeling of that condyle. So we are not claiming that we grow the mandible. We are claiming that we remodel the condyle that moves distally, displacing the lower jaw more forwardly. This is a very known effect of any functional orthopedic appliance, which is the same thing that every sleep appliance does as well. So what is the main side effect of sleep appliance that can cause in adult patients? So you have sleep apnea, and you put on a sleep appliance that moves the jaw forward, and you breathe better because you remove or you decrease the obstruction on your oropharynx by moving your mandible forward. But what is a common side effect of it? You create a bite situation where you sometimes you create a cross bite because you move your jaw so much forward, and now you cannot move it back anymore. It's the same thing, but you can use this body accommodation and adaptation for a good outcome. So if you establish the correct posture, you can actually remodel how the condyles is behaving. And again, she was 13, which is above the age we like to treat this case. We wanted to treat her when she was 4 or 5. It would be much quicker. It would prevent her from a lifetime of problems she had up to this age. But it's never too late. It simply takes longer to happen. So she did this, and let me show you here the comparison. You can see here before and after. And again, pay attention to how the lower jaw has responded. So it also helps to answer your question of how the lower jaw responds to a palatal expansion, palatal development. So it doesn't naturally, but if you take the upper development as a reference and you bring your lower jaw to meet that, that is the outcome you can get.
And so how much can the joint remodel safely to a millimeter, 2 millimeters, 3 millimeters?
The greatest overage that I have treated, I would say it was about 11 millimeters, like successfully. Another thing that I like those myofunctional devices is that they are flexible and the patients are only required to wear it for 1 hour a day and when we're sleeping. So whenever they feel tired, whenever it gets uncomfortable, they simply remove it. So we never lock the jaw in this forward position, causing damage to the joint.
But how is the joint remodeling 11 millimeters?
It's incremental, and it's a little bit of everything. It's dental alveolar adjustment as well. You can see here that both of the upper jaw is still did something. You could, if you get like cephalometrics from this patient, you can clearly see that a little bit of your upper jaw is also retruded because you are supporting this forward movement of your lower jaw on your upper teeth. So if you get proclination, if you get a common side effect of it is a little bit of not true retrusion, but your maxillary incisors, they do become a little more vertical than you would like, I'd say, because most of this forward movement of the lower jaw is being supported on the upper. So a little bit of that correction happens because of the upper jaw as well. You need to account for that. There is teeth inclination on the lower jaw that helps decrease in that space. So it is not that the whole overjet will translate to true orthopedic development. It's a combination of orthopedic and dental compensations as well.
And is the long-term health of the joint as it remodels around this mandibular forward posture, is that stable?
In my experience, it is. And it's not only stable, but these are the best cases. I don't have these patients, and I've been doing this for almost 18 years. I don't have these patients coming back complaining about any type of pain. I did before, just by using orthodontics, especially retractive orthodontics, when we lock the lower jaw in more retruded position, because now we create compression on the joints, we displace the disc, we cause inflammation on the joints because of this increased pressure. When we relieve this pressure, you do the opposite, which is moving forward. We are actually creating a better environment for the joint.
Mm-hmm. Mm-hmm. And then to solve this problem of having this kind of bite, what are you doing? You're doing orthodontics to move the teeth to support that new mandibular posture? Is that how that problem is solved?
You mean sleep appliance in adult patients, you're saying?
Well, so yes. So you're saying, when you reposture the mandible forward, what happens is that now all of a sudden for a lot of people, you end up with a posterior open bite, right?
Yes.
Because now you're edge to edge on the front teeth.
Yes.
And so the molars just aren't contacting. So
this case here, it did happen. Most of the case, you do get a transition phase where you only hit primarily on your front teeth. Mm-hmm. Because the first thing that happens is your lower teeth, they just procline forward and you get your upper teeth coming back, and eventually you just hit on those teeth and you lose a little bit of contact in the back. It happens on most cases, but if you just continue allowing the muscles to improve, allowing the occlusal plane to flatten, so eventually you get rid of the curve, we call it the curve of P. Whenever you get a flattening of this curve, you develop proper bite in the back as well. You just need to be patient.
The molars in the upper molars sort of erupt more to meet the lower molars with time?
They do. This is not for everybody. This does not happen like immediately. You need compliance. This is not like a solution for everything. You still need everything else from orthodontics to accomplish. This is not supposed to be a replacement for everything. This is the missing link, as I said. This is you train the muscles to also accompany what you need to do.
Mm-hmm. Mm-hmm. And in your case, wearing the sleep appliance and putting yourself into this edge-to-edge position on your upper front teeth or something like that by reposturing your mandible forward. How is that going to work out for you as an adult in the long term with
Okay.
respect to TMJ health and occlusion?
Good. So that's another difference from the myofunctional appliances. We never bring the lower jaw as forward as to create an edge-to-edge or even an anterior crossbite. It's always the class 1. So again, if you come close and see, I still have my central diastema here still not fully closed. Can you see here? So it used to be bigger. I didn't do any aligners, any braces, nothing. Simply the myofunctional appliance. And I don't have overjudge anymore. It's getting better. So I never came to this position on the help in an edge-to-edge situation.
So your sleep appliance does not put you that far forward?
No, it doesn't.
So it's limited then in terms of how much it can open up your pharyngeal airway.
But you know what's funny? What causes obstruction is not the jaw, it's the tongue. So what needs to come forward is the tongue. It's not the lower jaw. A very simple demonstration. It doesn't scare your listeners, but I have this particular skill, which is I can snore in many different ways. So I can snore with my mouth open, very easy. I can snore with my mouth closed. I can snore even if I bring my lower jaw here. I still have obstruction in the back. One thing that I cannot do is snore if I hold my tongue in the proper spot. So if I hold the tongue here, even if I try, there is no obstruction anymore because the obstruction in the oropharynx is the tongue relaxed. We have a muscle in the tongue called the genioglossus. The posterior attachment of that muscle is on the anterior wall of the oropharynx, basically the throat. Your throat is kept opening and closed depending on where your tongue rests. If you have your tongue resting and sitting against the roof of your mouth, you necessarily have your oropharyngeal throat open. If you relax your tongue, then you close. And it is not necessarily attached or related to where you hold the lower jaw. So you can have my lower jaw here, but if I hold the tongue in the proper position, I still breathe. That's why we love John Mills so much, because he knew about that like 60 years ago. Is all about the tongue resting position. Get the tongue to the roof of the mouth and you solve most of the problems in your life.
Yes.
And so we don't need to get this excessive forward movement. So typical sleep appliances, they will only lock upper and lower jaw together. They displace the lower jaw forward, but you're not necessarily bringing the tongue. So if you move your lower jaw forward, but you forget about the tongue, even if you refer these patients for active myofunctional therapy, which is the right thing to do. But if you're only resorting to exercise you do during the day, this does not necessarily translate to the proper position while you're sleeping.
And this gets right to the heart of treatments like the Inspire, which all that does is it electrostimulates the tongue to jut up and forward onto the roof of your mouth. It prevents it from falling flaccidly into your airway. So you're right, the tongue is the master when it comes to literally that which is colliding with the air to create the turbulence that's leading to snoring. But would you say, though, that sometimes mouths just aren't big enough to support a tongue posture in the first place that can limit sleep-disordered breathing, and hence why we have things like MARPE and jaw surgery? On the surface, you would seem like someone who would be against things like a MARPE and jaw surgery. Why don't we start with jaw surgery? Do you ever think that double jaw, MMA, orthodontic surgery is appropriate, or does that surgery scare you?
No, absolutely. This is the ultimate treatment for, depending on the discrepancy you have, depending on the situation you have as an adult, that's the only way to go. Because you might have such a deficiency that it cannot be overcome just by doing exercise and reposturing. One very obvious and clear limitation of a myofunctional treatment would be, how can you rely on the tongue as the driver for your growth if it doesn't even fit in the roof of the mouth to begin with? So when the palate is so narrow that it doesn't accommodate the tongue, it's clear that you still need to do something there. You need to create that expansion. Doesn't matter if you're a kid or you're an adult. So if you want to get your tongue up, you need to have space for the tongue for it to move there. Yes. So we do MRP, we do everything you can imagine. But every single case, they get to do myofunctional training as well. So that's the only thing we I think is not controversial. I hope it's not controversial anymore. You correct the shape, but you need to address the form as well. So sometimes that correction must be a little bit more dramatic. So it might involve surgery as well. But even if you do surgery, that's when the muscle training is even more needed, because that correction happens in an instant. You go to sleep and you wake up and you have a hole in your face, a hole in your mouth.
Yeah.
But you still have the old brain, the old memory, and the same muscles. You need to learn how to use it. It's the physiotherapy that follows any type of orthopedic surgery.
Mm-hmm. Yeah,
it needs to be done.
Right. Form and function. And by the way, before I forget to ask, do you treat adults? Do you use MARPI, or are you mostly a pediatric orthodontist?
No, we do. So my work here in Canada, since I moved here, I'm working more as a consultant. I don't have my clinical, I'm not licensed as a dentist here in the country, so I'm working as an educator. So I have lots of dentists who I collaborate with. I provide mentoring, consultation, and we discuss cases, case support. Is many different levels of collaboration. That can be in office, in case, and helping with implementation of this airway focused approach for dentistry. That's mainly what I do. And so I have some closer partners that will work with me. One of them you met, Dr. Karim Kadri, that we met with Dr. Ilya Lipkin's course. So he's doing lots of, he did my MRP himself. So I work in
Canada. Is he in Canada?
Yes, in Windsor, Ontario. We are right across the border from Detroit. So he's doing MARP in kids. The younger patient he has, I would say, with MARP, she's 12. So she has a 12-year girl with MSc in that case. And we have adult patients such as myself, and we have many others too. And between a baby doing tongue tie release and an adult doing MARP, everything in between. Mm-hmm. Mm-hmm. And my work again is in the background, helping with treatment planning and making it happen. So I don't.
Do you think at some point you'll become licensed in Canada and start treating patients?
That's a goal. But I'm very happy in that situation where I collaborate with many dentists, because I don't see only the patient that I would myself. Is a much broader pool. So I still take pride on helping those kids myself, providing proper advice and following them up. It's not a simple case of seeing a case and giving an opinion. It's actually following. It's monitoring how the patients progress. So I get to see them as they come back. So I follow through the whole case. And I also do team training, because if you want to do this airway focus approach, you can do this alone. You can, being a dentist, that's not something you can do by yourself. You need a supporting team. You need, or your whole office understanding what is it that you need to do. Most of the time you engage with your patient is not on your dental chair anyway. It's all about education. It's about monitoring. It's about enhancing compliance. It's a lot of talking and education rather than using your hands to do something. Yes. So we need a supporting team to do that. So yes, I plan on getting this, but it's working so far. And I'm very happy with the impact that we are able to provide.
Well, I think you're very well suited for education. You're a very good interviewee, guest. I can tell you're very passionate about this subject matter. Did you have any more cases you want?
So just because you're asking about MARP, what do we do in older patients? I would just show a MARP case that we like a lot. So this is the type of case that you cannot possibly think that you would at least start the case using any type of functional approach, because this is like too much. This is lots of compromise. This is a lot of deficiency that you need to compensate. You cannot rely on exercise to overcome that amount of limitation.
How old is this patient?
He is 15.
Mm.
So that's a patient where Dr. Kadri opted to go with MARPI. We worked on the treatment planning together. So he got the MARPI. This is just 4 months later after treatment, and you see a very good development on the maxillary arch. Here you can see how the maxilla opens in this forward and downwards position too. So you see that, pay attention to that canine, and there was a crossbite here on this central. So he had a face mask, but he confessed that he was not the best patient on wearing the face mask properly. So most of it is truly due to the maxillary expansion.
Mm-hmm.
And now
it's a very interesting point you just made, because a lot of the MARPI plus face mask before after photos, people attribute the class 3 correction to the face mask, but it's not clear how much of the class 3 correction is just due to the interiorization of the midface and the maxilla that results just from the skeletal expansion.
I agree. So we like a lot of how Dr. Ilya Lipkin approached this. He said that why not? You get your facial sutures to become more flexible while doing the expansion. So why not take advantage of it? So it is never a bad idea, but most of it is truly because of the expansion, for sure. Mm-hmm. And again, we transformed. The goal here is he couldn't breathe. So there is one nostril. Let me go back here. His left side nostril was completely blocked. We always see those patients together with an ENT that we refer to and we get referrals from, because again, we treat them for the airway health primarily. So you want to know how they look like in the beginning. We want to follow up these patients as well. So he had a severe nasal congestion on the left side, and that was significantly improved. And you can clearly see, even just looking at his nose, on how this changed. Not only, so it is not only an aid to a future orthodontic intervention, because he is getting braces obviously to correct alignment, but now we transformed an impossible case into a very manageable, very straightforward case now after the proper skeletal development.
And how come no diastema is forming, doctor?
Because it was formed, but once we open, we slow down the turning protocol to 1 turn per day. So he had such a severe crowding to my attention here that as soon as he got a diastema after the split, it almost instantly started closing.
So the ligaments of the teeth just kept everything, they kept the teeth together?
Yes.
This is another thing I think doesn't get mentioned enough, is that if you turn slowly enough, you can manage the diastema just with a slow turning protocol via the ligaments of the teeth.
So initially, we need to build up tension enough to split the suture. But once it's open, there is no need to go that quick. You are actually more prone to failure if you go too quick, for asymmetries to damage the sutures. You want to do that slow after the suture is open.
Mm-hmm. And what amount of this expansion do you estimate to be dentoalveolar versus truly skeletal in this
case? We are still, we have obviously his initial CBCT. We are still waiting to consolidate to do the final one to compare to this better. But we do have a little bit of inclination. You can see here on the premolars. Mm-hmm. So there is a little bit of inclination, which indicates dental compensation. It is not, although it's supported on the palate, it is not necessarily 100% skeletal by any means. If I were to guess, and at this point will only be a guess, I would say that at least a good 20% of it, 20-30% of it is dentalveolar.
I appreciate you being honest about that, because I think that also doesn't get mentioned enough. Have you been following developments in the MARPI space at all? And have you heard of the FaceGenix midfacial expander? It's
the FME. I've never used it, but I've been reading. And I followed Dr. Emanuele a lot, and I appreciate his work, and I respect so much what he does. Very honest approach to it. That's my main source.
And are you intrigued by the potential of a totally non-tooth anchored MARPI?
Definitely, because I want to see how this develop. I still don't have like a strong opinion on it. That's definitely a point of development, because if you don't have any rest on your teeth, you definitely decrease the amount of dental alveolar compensation you get on these appliances. The MARP is supposed to have those arms just as stabilization thing to get more symmetry but it's supposed to have, because of the skeletal anchorage, primarily skeletal development. We know that is not entirely what happens. So when you remove the dental support, you get more skeletal expansion. But as I said, I don't have any case myself. That's only what we see online. I don't think that they are widely available, the FME appliances, anyway. But
they're not, and they're expensive.
Yeah, so I'm very curious to see how it goes.
And in this patient, he started with I don't know if his head is angled or if he actually has a cant.
So now both. No, not the cant. It's more angulation. Yes. One thing that I like to do, as I said, we do have the CBCT to do the proper planning. But while taking diagnostic photos in the beginning, I don't like to direct patients in position that I want to capture them being their natural selves. So if they have any postural compensation and they are naturally like deviated or the neck is protruded or anything like this is part of the problem. Mm-hmm. And then we do an intervention and we do a simple expansion and we repeat the posture on the same position and they naturally align their heads and are now in a much better position. This is also an outcome for that treatment as well.
I agree. And it looks like his neck posture has corrected itself a little bit.
So we have this profile here. Not the full profile. I just want to highlight the forward development here. Look at his upper lip, on the volumes of the lips, the stronger cheekbones and everything. So it's much more than just expanding the jaw superpole line. This is true, as you name it. This is a true jaw hack.
Yeah, indeed. Do you anticipate this patient will need any kind of SFOT to help finish off with the relief of the crowding or to get the lower jaw into matching? Or do you think this can be finished without any periodontal support?
It can. He will be able to do that because he came from a very significant crossbite initially. So he's not that far off. As I told you, when you see this, you get an idea that it's too much. But just removing the appliance and doing the alignment and getting space to get that incisor into position, this would get proper inclination and torquing of the upper teeth, and that would be probably just what he needs.
Fantastic.
So yes, there are cases that we get a situation that is too far. The discrepancy between what you get on the upper is too different. You need to be more aggressive on the lower. That's when we would consider the type of intervention.
Mm-hmm. You seem to be in touch with many of the top MARPI people. Do you also have opinions on your favorite jaw surgeons internationally or in the United States?
So I have never worked myself as a clinician in the United States, so I wouldn't say that I had a patient share with anyone. I basically follow most social media, so I would say Dr. David Alfie is undoubtedly a good name, a good reference for it. I also like the work, I guess his name is Dr. Colpenson for the Breathing Institute, because of this intimate relationship. It's facial jaw surgery is done for the right purpose. Mm-hmm. That's basically what we like. The cosmetic outcome is just a natural result of it, not the primary goal. You do it to restore proper function, and it naturally looks more attractive.
Yes.
It's a consequence.
Yes. And I see that you had a graphic around breastfeeding that you never got a chance to show. Can you talk us through this breastfeeding image here?
Sure. So in the topic of why breastfeeding should be encouraged from many different reasons, specifically due to the craniofacial development perspective, it's because how the muscles work differently when the baby is exposed to breastfeeding in contrast to bottle feeding or other sources. While breastfeeding, the baby needs to project the lower jaw forward in this suckling movement where the tongue goes underneath the breast, compressing it against the palate, which creates muscle strength in the tongue for when they're done, resting the tongue in the roof of the mouth should feel natural and should not feel a challenge because the tongue is being exercised to do so. Breastfeeding also encourages nasal breathing because doing so teaches the baby how to coordinate swallowing reflexes with breathing. So they must resort to nasal breathing while breastfeeding. And because breastfeeding is harder, they need to work harder to extract the milk from the breast. It takes longer, so they spend more time doing this rather than when they are fed using bottles because they had huge holes and the milk is easily ejected. So they take longer to feed, doing more exercise. So they become simply stronger babies, or the facial complex simply becomes stronger. So it stimulates, it's a very different muscle pattern being developed. When you are fed using bottles, this is simply a suction movement. You just suck against it. And while suctioning, you move your tongue backwards. So the tongue is displaced backwards into the oropharynx, which creates the need to create this forward head movement in order to assist with swallowing, because you don't have the oropharynx open this way for the swallowing movement because the tongue is displaced backwards. So you need to do this forward head movement, and then you learn, and then you stop feeding, but you still maintain the same posture. Another thing that suction habits will create is very strong masseter muscles in contrast with lip seal. You don't need to use your lips to have the bottle there. So you suction, you develop your cheek muscles they get strong, and they get to prevent the natural transversal development of the jaws. You simply do everything the opposite. Instead of training the proper muscles, you highly stimulate those who should not work, and you don't give proper stimulation to those that should work. So you create an inverse muscle behavior that will lead to improper craniofacial growth.
Wow, doctor. Yeah, man, if that's not a testimony as to the importance of the mechanical aspect of breastfeeding, not even to mention the chemical component of breast milk compared to the swill of most formula, yes. I don't know what is. And what's the purpose of this gauge, this syringe-looking gauge that's shown on the bottom left image of the bottle feeding? What's that telling us?
It's creating the idea that you need to create vacuum to remove the milk from here. So it's about suction, and that vacuum. If you do this with your mouth right now, you feel where the pressure goes to. So you are compressing your jaws. You're not stimulating growth. You're doing the opposite. You're creating vacuum inside your mouth. That's the way to extract the milk from the bottle when you do this.
So bottle feeding is like doing the fish face where you go.
Yes.
And you can feel the cheeks compressing the jaws. Whereas breastfeeding is more of a, you're coming up and you're pressing with you're massaging the milk out of the breast. It's not a suction. It's more of like
not a suction.
Because
it's a suckling thing, as they call it. It's the tongue going underneath the breast, compressing the areola against the roof of the mouth, ejecting the milk, and coordinate the peristaltic movement. So they learn how to swallow. So I have another slide here showing what the milk, how does it goes below. So it's not only in the oral phase of swallowing, but also esophagus too, because you need to learn how to do the whole peristaltic movements. And that's movements that transition the food to the stomach. It begins with the tongue. So that waving movement that needs to begin with the tongue.
Wow.
You don't learn how to do this by feeding otherwise.
Do you know of any devices or man-made inventions that can replace breastfeeding to teach this exact motion?
So in the absence or the impossibility of breastfeeding, the best thing you could do is either feed from a spoon or those sip cups. The whole idea is the baby need to acquire the food. So if you have a spoon, don't put the spoon inside the mouth. So you touch the lips and you will wait for the baby to go towards that spoon to get the liquid or the food from there. The sip cups, the same thing. They need to do the movement. They will move. They will put the water, the liquids inside the mouth, and they will start the same swallowing movements. You cannot get food and put inside a baby's mouth.
Which sippy cups are you referring to? Are you referring to something like this sort of thing?
Yes. So they have, yes.
Because with this, there's the baby needs to press up against this part of it, and it's like a button on the inside where when the baby clasps it, it releases, it opens the valve so that the fluid can flow. So if you spill this over, it won't spill, but if the baby clasps it,
yes,
it opens the valve so the liquid can
it's not a suction movement. It's almost like a chewing. He needs to close on it.
Instead so you like these cups?
Great suction. Yes, that would be, again, it's not entirely mimicking breastfeeding, but it's not detrimental because it's not establishing suction.
And how come no one has invented a device that really does mimic breastfeeding? What's the holdup there? It would seem like that would be a world-changing invention.
There's an opportunity.
All right,
let's get together and make that happen.
I've been saying it for years that I wanted to invent a set of fake breasts that mimic the breastfeeding, and I was going to call it the rack. I just haven't been able to find a partner that can really help me make it happen. So
I think we can jointly come up with some solutions.
I think if we had $100,000 to spend on prototypes and getting it figured out, I think we could do it.
Let's continue that conversation.
All right, doctor. Well, why don't we end it on a hopeful note for a cool new invention around breastfeeding. I want to thank you for your passion, your insights into how to create healthier children that can avoid a lot of the difficult treatments like the MARPs and the jaw surgeries that we as adults have struggled with. Yes. Expensive, painful, dangerous stuff that are best to be avoided if possible. You've given me insight for my own daughter and my soon-to-be-born second daughter. And so where can people find you if they want to learn more about you and your work?
Sure. First of all, again, I appreciate you so much, the work you have done for all of those years in raising this awareness, in keeping up with the conversation and stimulating not only general public, but us professionals. We don't get one of us to do what you do. And it's truly commendable. It's very important because the public needs to, every single person, they need to own their health. That's something that you can trust somebody as your sole advisor. And having this responsible source of proper information with proper research, you do have a very significant pool of professionals providing you those interviews. And I'm very honored to participate, to be here as well. So again, thank you very much for this opportunity. And I hope you can just be the first conversation and can move this forward. I do have my Instagram account. You can find me there. DR is in Dr. Paulo Soares, just my first and last name. You can find me on Instagram. I have my website as well, drpaulo, then it's the same name.com, where I offer my training course and mentorship. And there are many different ways where we can collaborate with doctors. Depends basically on their specific needs. So I'll be happy to discuss this with anyone who wants to implement and become an airway focus provider.
That's wonderful, doctor. I will put links in the description to your socials and your website, and all the best to you.
Thank you very much. Thank you very much.